So a lot of the recent attention in the media certainly has focused on the newer targeted therapies as well as immunotherapies and cardiotoxicity. Meanwhile, we have many patients who continue to receive traditional cytotoxic cancer therapies such as anthracyclines, fluoropyrimidines, and fluoropyrimidines in particular are a class of agents that have not been well studied with regard to mechanisms of cardiac toxicity that we still continue to see very frequently. Patients will present with coronary vasospasm, which has been well described, but we still don't have good methods of risk stratifying patients. We don't have great methods of protecting them against toxicity. Many practitioners will use tried and true protective strategies such as nitrate therapy, such as calcium channel blockade, but we find that many patients still fail these therapies and they have to stop the fluoropyrimidine, which is oftentimes a first-line treatment for their cancer because of the cardiotoxicity. This is an area that certainly has been recognized for many years and even decades, but where we don't have good data to support the approaches that we're using. Similarly with anthracyclines, from a public health perspective, many patients continue to get anthracycline therapy for breast cancer, leukemia, lymphoma, sarcoma, and these are patients in whom the ability to give potentially higher doses of anthracyclines could be very beneficial for treatment of cancers. This is a scenario we often see in patients who have secondary malignancies for which they require anthracyclines both the first time around as well as for the second cancer. And so in these patient populations, although the presence of cardiotoxicity has been around for decades, we still do not have strategies for risk stratification, for cardioprotection that are supported by strong evidence bases.